when I would treat migraines, it used to be believed that migraines had to do with either vasodilation, vasoconstriction, or both. And that was really the underlying trigger of migraines. And what we now know is that's not the cause of migraines, that's the sequela of migraines. Meaning the migraine causes the vasodilation, vasoconstriction, or both. It is not the cause of the migraine. And when I started to look into that research, you have this sort of aha moment, and it's like, okay, well, no wonder. I mean, sometimes the protocols I would use work, just like sometimes ergotamine and some of those other compounds that were used, in orthodox medicine would work, but there was a pretty high failure rate. And once you sit there and understand, well, wait a minute, I've kind of been hitting the wrong target, or at least attempting to hit the wrong target. The good news about herbs is they are not target specific, meaning they can still sometimes work because they're affecting many things, not just one, receptor site or something like that. And what I have noticed is since I've incorporated this into my clinical practice, my ability to help people with migraines has increased significantly. So that's what we'll be talking about today. So basically a migraine is basically defined as an episodic neurovascular phenomenon characterized by recurrent attacks of unilateral headaches. The word migraine comes from the Greek hemicrasia, which means one-sided. And so migraines tend to be on one side of the head or the other. And most people get them on the same side most of the time. But I've had a couple of patients who actually their migraines switch sides every now and then. So that's not impossible. And you can also have migraines that even though it's one-sided, it can kind of go like from your eye and then wrap around down to the base of your neck. So if it's not just here, don't assume don't say, oh, it couldn't be a migraine because it's, they can be broader. So approximately 10 to 14% of the world's population suffers from migraines. Unfortunately, women are much more likely to experience migraines than men, about 3 times more likely. About 18% of women develop migraines, about 6% of men. And again, migraines are primarily divided into 2 quote-unquote basic types. You have migraine without aura, that is the common migraine. That is the most common form of migraine. And then you have migraine with aura, which is called the classic migraine, because in all the ancient medical literature, this is the one that they usually describe. This is where you have the prodrome, where you have visual effects for the most part, the aura, the seeing of the aura. And so that was often described in the ancient literature going back to the ancient Greeks, and hence that's the classic migraine. It is less common. It is also usually less severe. So migraine without aura, you have moderate to severe, and yes, you can have a relatively mild migraine. Relatively mild migraines are still kind of crippling for most people. Severe migraines are absolutely debilitating. So you're talking about a migraine with pulsating pain, usually worse with movement. There's also often nausea, cutaneous allodynia, that is your scalp hurts, the muscles are tender. You can also have light sensitivity, and as I said, this is the most common form of migraine, and sufferers tend to have more frequent and severe episodes than people with the migraine with aura. Migraine with aura, there is a gradual onset, a period of usually 5 to 20 minutes, it can be 30 minutes, where you can tell it's coming, and there's this aura, things kind of look funny. Sometimes they sound funny. They often are much more self-limiting, meaning they will last only 60 minutes or less, and there is, again, accompanying visual, auditory, and sensory symptoms. These tend to be much less debilitating. They're also actually significantly less common. There's something else I want to tell you. Some of my patients, I've had patients who came to me who get migraines, and you'll see in a moment the way they classify migraines is the frequency. And so on one level, these people will say, you could say they have low frequency, they have less than 10 migraine days a month, but some of these people, their migraines last for 3 or 4 days at a time, which is just horrific. You're talking about 3 or 4 days of taking heavy-duty medication, being in a dark room, often with like a hot or cold cloth on your head, basically in a fetal position, just trying to get through it and not trying to vomit. It's delightful. Anyway, so frequency, there's what's called episodic migraine. Episodic migraine are fewer than 15 headache days per month. Well, let me think, wait a minute, how many days are in a month? Yeah, roughly 30 in the average month. So, I mean, we're talking about less than 15. That's half the month. So, less than 15 headache days per month, often progressive. So, if you have episodic migraines, people with episodic migraines, about 2.5% to 3% of migraine sufferers per year develop chronic migraine. So, the longer you have it, the more likely you are for it to get worse, not better. Low frequency episodic migraines, 10 or less headache days. Isn't that great? And then high frequency, 10 to 14 days per month. And then we have chronic migraine. That's more than 15 headache days per month. This tends to peak when people are in their 40s. There are other types of migraines. We have menstrual migraines, which only occur at menses. There is a strong hormonal component to this. We have basilar migraines, which is the basilar artery. We have abdominal migraines, which occur mostly in children. And children with, mostly. Children with abdominal migraines have a very high risk of going on to develop either IBS, IBD, and other classic and the sort of more orthodox migraine later in life. Also suggesting that there is a potential link between gut inflammation and migraines. Because we also know there is a strong link between neuroinflammation now and migraines, and gut inflammation is linked to neuroinflammation. Oh, there's a picture kind of emerging there. We also have ophthalmoplegic migraines, which is basically in the eye, as well as retinal migraine and vestibular migraine. But these are all less common. So how do we explain migraines? Because, as I said before, the belief was that migraines were caused by insufficient cerebral blood flow and rebound vasodilation. That was the belief. And a lot of the medications used to treat migraines, which basically addressed this, often would work. So they figured, this is what causes them. And as I said, recent research, this is research mostly done since, the beginning of it starts around 2012, but most of the research gets published in 2015, 16, 17, 18, which shows that does not adequately explain the phenomenon of a migraine. And that vasodilation is more likely, in fact, at this point we know for a fact, is actually a secondary phenomenon associated with the neuroinflammation. And so that is not the underlying cause. So then, what is? So the good part about this is we now have a better understanding of it. The bad part is, and if you get the article, you'll see this, it's complicated and there's a lot of potential causes. And here's the thing. I doubt any one of these causes is the cause. In almost every case, you probably have 2, 3, or 4 of these phenomena occurring at the same time. And in fact, some of them actually acts as a cascade, so one triggers the other. So for instance, we have altered cerebral perfusion is potentially a cause. So it's not just circulation, but perfusion of ions throughout the brain. We have cortical spreading depression, and this causes a wave of depolarization with altered blood flow, inhibition of bioelectrical brain activity, and increased inflammation of the trigeminal nerve. And the trigeminal nerve here is really important, all right? We'll get back to that in a moment. Increased cerebral calcium influx, which is mice, has been shown to trigger cortical spreading depression. So that plays a role. So one, again, is affecting the next. Low serotonin or low magnesium levels. How many of you have low magnesium levels? Way more than raised their hands. 50% of all Americans have low magnesium levels. The problem is, if you go to the doctor and you get a serum magnesium does not reflect tissue magnesium. So therefore, your blood magnesium can be perfectly normal, but that does not tell you that what your tissue level is or cerebral magnesium levels. And by the way, for increasing brain magnesium levels, you want to use a specific form of magnesium called magnesium threonate. That is the one that actually gets into the brain tissue.
Say it again.
Magnesium threonate. Yep, it's in the article. All right, so low magnesium levels are really common. And of course, with low magnesium, you get increased inflammation as well. An inherited lower activation threshold of the trigeminocervical pain system. One of the things we see with migraines is it tends to run in families. All right, so if one of your parents has migraines, you have a significantly increased risk of also developing migraines. It doesn't guarantee it, but it means you have an increased risk, suggesting that there may be genetic factors, and one of them may be this inherited lower activation threshold of the trigeminocervical pain system. And we talked about just a little while ago with cortical spreading depression, one of the things it does is it increases inflammation of the trigeminal nerve. All right, the nerve goes through here, up into the back of the sinuses. And this is really important because many of the things that we are going to now use, in fact, many of the things that are now being used in orthodox medicine include things like medications that are basically sprayed up the nose. All right, so you're getting directly at the trigeminal nerves. Also, elevated levels of calcitonin gene-related peptide, which is CGRP, and this causes increased vasodilation, mast cell degranulation, which means it increases inflammation of the tissue and increased inflammation. Also, increased levels of pituitary adenylate cyclase activating polypeptide, substance P. Substance P is the compound that allows your nerves to actually feel. All right, so that's what, like for instance, if you've ever used capsaicin topically, capsaicin depletes substance P in the nerve endings, so you no longer feel that pain. But this is basically regulating substance P, so you feel pain more acutely, as well as increased levels of interleukin-1 beta, which is a pro-inflammatory cytokine. Don't worry if some of these terms, if you don't know what a pro-inflammatory cytokine is, etc. What are we talking about here? This whole list, and there's some more, this whole list really is talking about, for the most part, neuroinflammation, and maybe a little bit more neuroinflammation. We also see glutamate dysregulation, and glutamate is an excitatory neurochemical. We have mitochondrial dysfunction, and this one is really interesting because with mitochondrial dysfunction, we also, to drop down on, we see impaired mitochondrial methylation, especially in women. This may be one of the things, along with hormonal differences, that explains increased migraines in women. So, if you have decreased ability to methylate, that means you have decreased ability to uptake things like B vitamins, but also a decreased ability to get rid of metabolic wastes. So you'll often see people who have impaired ability to methylate have higher levels of lead, higher levels of mercury, higher levels of the forever chemicals, all sorts of compounds which are not only pro-inflammatory, these things are, carcinogens. There are a whole range of issues that come with inability to methylate. Now, so a lot of you might say, well, I better go and get to the doctor and get an MTHFR gene test, to see if I have a defective gene SNP. The reality is, it's okay, you can do that. The information you get from those tests is actually rather limited. We don't fully understand what most of it means. But we do know if you have a homozygous gene SNP, that's for both of them, your ability to methylate is reduced from, say, 100%, well, nobody's probably 100%, let's say 90%